scoot forward, moving the feet out because I want weight on these feet. And if they're under here and they lean forward, what happens to the feet? They come up, right? So I want the feet out here so that they're flat and we can get weight on them. And we're just doing the 4-point weight bearing. So whatever's wrong with the upper extremity that has to be guarded, whatever's wrong with the lower extremity that has to be guarded to keep it from going this way or rotating in because we don't want the tone to kick in. All that's the same, okay? So we're gonna let them come up in increments. We stop them again right there. We're going to inch them forward. Again, feet still flat on the floor, hands still flat on the table. And now I'm feeling that through my toes. I mean, I am literally making sure that I'm not shifting to where the weight is through the toes of my feet and back. Okay? So you're really wanting to make sure that they are getting weight bearing through all 4 extremities here. It's just a progression with the table. And now at this point, you're going to have them move their feet back a little bit. And they're still, now we should have some really good weight bearing through both feet with no shift at this point. So we are literally going sit to stand through high perch, which is what's showed here on this. And don't turn me in for copyright infringement. We are literally going sit to stand through high perch. You want their ischials hanging off the side of the table, but it is doing the work for you. Now, as the therapist, I'm going to scoot the feet back one more time. If it's my left side that's weak, I'm going to get over here. I'm going to place my knees on either side of this patient. I'm going to get the pelvis and I'm going to pull them into standing. It's that easy. When I go to sit them back on the table, if I just lean them, I don't have anything that those ischials are not going to be there anymore. So I want to kind of bend them forward a little bit and then set them. Pretty much simultaneously as I start to bring the table down a little bit, if I'm going straight back down. If we're just leaning for a rest break, then that's okay. We can just lean against the table. They can put their hands, the good hand on it, whatever. Now, when we do go to high perch, if they have a flaccid arm, we are likely going to throw it in a sling at this point, because it's going to be very difficult for you to manage an arm here, a leg here, a pelvis here. You're going to run out of hands. So at this point, we're just going to have to tuck it away if the left side is weak. We're just going to have to we're going to use it for the 4-point weight bearing. And then right before we go, we're going to have the sling on, and when we come up, we're just going to tuck it away. We don't want it just hanging against gravity, pulling down, subluxing, and we don't want it hanging in the way to get knocked, and when we start the next couple activities, it's just going to be in the way. So sling for flaccid upper extremities. When we start standing and gait is where we're going to, is what we're going to do with it, okay? Just go ahead and mention that so I don't forget to mention it. Again, it will be in the way, it'll get injured. We don't want it to sublux. We want it safe. And it's not going to be functional. And I do not have enough hands by myself to manage this here, manage this here, manage this here, manage this here. It's not possible without a second person. And the odds that you're going to have a second person are not real high. If you do, you can have them address the arm while you address everything else. When you're by yourself, you're going to sling it. Okay? If it's spastic And they can use it great. If it's spastic and it goes back after we've used it for the weight bearing stuff, then so be it. You just gotta let it go at that point. We've used it in all the other activities. It's gotten its usefulness. We've done what we need it to do. Now if we get a little extensor tone, is that gonna be a plus or a minus? It's kind of a plus. Now we want them to stand up. So, we just kind of let it go at this point, and if it draws up on the top half, we don't really need it anyway. Stays out of the way, or if it stays relaxed, then we'll use it. But once we stand, we're a little less focused on the upper extremity because we have other things to manage. Does that make sense to everybody? Now, we can't disregard it completely because you can't leave a flaccid arm hanging about. So it does have to be addressed, but it's going to be addressed in a different way than what we did it for sitting activities. That makes sense to everybody. Okay. I won't forget to mention that because, again, sometimes I do things so automatically that I forget that they're not common knowledge. So, we get them up into high perch, and whatever's going to do with this arm, we do with this arm. And then we will start lowering them down a little bit at a time. So we have our knees bent slightly. No pushing off, even if both arms work. So if we're dealing with an ataxic person, that both arms work, there is no pushing off. Our normal development says that we don't push off from a chair when we stand. This is the proper placement for hands. 2 hands that work, 1 hand that works, 1 hand that works. They have to go on the thighs. If you allow the patient to leave them on here, they will use them. Here. And then we will facilitate the sit to stands from a slightly lower table. Guarding the knee, I'll bring the patient up here and show you, but guarding the knee, and you will do from one height of the table, and you will slowly go down and build up the sit to stand. So it'll be high perch to eventually where hips and knees are the same height. That's your goal. And you're standing on top of them, so I do not want you to get down to see if the hips and knees are exactly the same height. You should be able to get a pretty good idea from your vantage point. Do the best you can. Again, I don't want you abandoning the patient to get back from them and see, are we exactly hip and knee compatible? Are they 100% the same? That's not the point, okay? Perfection in that manner is not important. We do want to see that they are pretty close. Okay? So that's what you're going to work on as far as your sit to stand. So we're going to do that through high perch. If we flip the page, we're not going to allow pushing up. The hands are going to go on the knees or the thighs if they need support. The 2 things that we want to do is promote hip flexion and facilitate trunk extension. And then in the beginning, we will facilitate these movements just like we've done with everything else. And then we will progress to letting them err and fix it themselves. No different than everything else that we've done to this point. That's all the same. The next page is kind of like a reference sheet. This is one of those that you can take with you wherever you go, on how to use. Remember, you had the bed mobility one like this, how to use sit to stands as an entire treatment. If you're stuck in a room with somebody, we've got COVID going around, they've got something that they're on precautions and they cannot leave their room, you can do an entire, probably 60-minute treatment with nothing but sit-to-stands and very little equipment. And this shows you how to progress those sit-to-stands just like we did the bed mobilities. You can use breathing exercises. You can have them take a deep breath in. You can incorporate breathing exercises with sit-to-stand. You can remember how we used the TheraBand as Carly was trying to get up? You can do the same thing. You can use TheraBand as they're trying to come forward. So you can make that part of the sit-to-stand resisted. You can put TheraBand around the thighs and make that part resisted. So you can like make different parts of it resisted as you go through the progression. You can change the foot placement. You know, normally we go here. You can make them go here. You can make them go here. You can make them go here. Go wide. Change it up. Change the base of support. It makes each sit-to-stand very differently. Make them do it with their eyes closed. That makes it very different for them. Remember I said that it was they get so mad when you ask them to get out of the bed on the wrong side. Make them adjust their feet in a different way. They're like, no, your feet go here. I understand that. We're just trying to challenge you. We're trying to make it harder. So I want you to stagger your feet and close your eyes. Who does that?
You, right now.
Right, exactly. I understand. No, you're never going to do this without me. That's the point. If you do this stuff with me now, then when you have to get up like this from a higher chair and your eyes open, you'll be able to knock it out of the park every time. So it's just variations of what they have to do. It's that overtraining principle again. Time it. How many sit-to-stands do you think you can do in 30 seconds? Ask them what they think their capability is, and then time it. See how far off they were. That gives you a good idea of what they think their limitations are. Ask them where they need to sit-to-stand from, and if you can't do it in the exact manner, then simulate it. Like if they need to do a car transfer, what kind of car do they have? You know, are they going to sit down and come around? Or are they going to step in? How much clearance do we have? Simulate it. Make it as real as possible. What all do they need to be able to do? Are they going to have to step over a tub? Find out how tall it is. Simulate your sit-to-stands. And I mean, these are more transfers, but you know, you can, because you would have to sit-to-stand from a car, how do you have to get out? How do you have to get in? Because a car seat can be very low, very low. So in that instance, then you could take it back to the mat table, measure from how far from the floor the mat table is, and make it the exact height of their car. And make sure that they can sit-to-stand from the car. So you can tailor anything to make it more personalized for your patient. You can put the weighted vest on them. You can say do 3 really fast and then 2 really slow. Vary up the speeds. There's all kinds of things you can do with sit-to-stand because you use every single muscle in your body to do sit-to-stands. All your anti-gravity muscles are working. All your lower extremity muscles are working. The exception would be if you don't let them push, you could even incorporate to get them to come forward more. If you're having issues with them doing an anterior weight shift, have them reach out towards you. Now you've got the uppers involved too. So there's so much that you can do just with one movement. When they stand to sit, you can really kill them with this one. How many patients want to flop? No flopping allowed. And I say this a lot. You'll get a patient on a walker and they'll be coming in and they'll be, we work so hard on the turns and then it's, I'm like, okay, the approach is good, but the landing needs some work. Because they just get around there and they think their job is done and then they just, no. Okay, so we're gonna get right there. With our neuro patients, we're not gonna have them reach back. Not a normal movement. Not a normal movement. So now what are we gonna do? So we still can't tell them to teach back or to step back till we feel the chair. That's okay. That's not abnormal in any way. A lot of people would, kind of want to feel something before they sit down. Then you're going to tell them, what are you going to tell them? What do we do to counteract if we can't feel?
I guess you can facilitate with your hands.
Like what is it that you want? What do you want to facilitate? What do you want the patient to do? To sit.
To slow down and sit.
Slow down. Where does the weight need to be?
Would you have them lean forward more? Would you have them lean forward more?
Yeah. I mean, because they can't sit down this way. They can't sit down straight. So you need to facilitate them forward. So sometimes you can, again, use the hands, clasp the hands. If we've got one hand that doesn't work great, they can get a wrist. They can support, so we can incorporate the arm, support the active assistive exercises, and we can pull out and down and kind of let the body follow the arms. And, okay, there's an egg in your chair, don't break it. You're gonna sit down so easy that you're not gonna break the plastic egg in the chair. Whatever. I mean, just, that's how easy you have to sit. Your rear end should never sit in a chair harder than that. So, you gotta use your leg muscles. Easy, 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 easy. And so sometimes you really have to bend them way forward in order to get that easy set to start with. So there is a lot that once you go through high perch and you build up the ability to go sit to stand from a relatively normal level that you can do with this one movement. So, it can be very beneficial to your patient too, because then they know no matter where they get thrown in a chair, they can get out of it. No matter what car they have to ride in, they can get out of it. So it's a really good thing. So so that's your when am I ready, how to assess, and the progressions. That was the first part of the packet. The other pages are just some handholds and some placements of like your leg, foot, knee in respect to patients that you have in standing positions. You can see the patient has a gait belt on, but that's not where the therapist's hands are. That's because it's a neurotherapist and that's not what we do, but the gait belt's on for, the purposes that if we were to need it. We will sometimes use the high-low table. If we're like in high perch, we can still use that high-low table on the good side for support. When we learn the progressions for stance and swing, we use the high-low table like a bar, like a ballet bar. We use the high-low table.
To the side.
We use it as our thing to lean on and to hold to in a high position. If you are standing, here's how to use like the bedside table to support like a limb. Like again, if they can't support it themselves, we've got to throw it in a sling because we just don't have the time to kind of teach you. That one's just kind of a FYI for like future reference if you're not knowing what to do when we go from weight bearing all the time to standing them up, and then okay, now what do I do with this upper extremity? That's a good one to do. Still keep it on the table when they stand. You can still weight bear through it that way. And then it doesn't take as much management of the therapist when you can adjust the table so it doesn't like flop off every 5 seconds. But again, for time purposes and safety purposes, we'll just be throwing a flaccid arm in a sling. Depending on the height of your patient and the height of you, a stool might be appropriate, a stool might not be appropriate. So I can't say always use a stool, never use a stool. It's going to depend, because you as the therapist, you may have 2 patients that you use a stool for and 2 that you don't. You're the same exact size all day long, but your patients aren't. So you have to decide where your body mechanics make the most sense for you to sit to support the lower half of their body versus stand to support the lower half of their body. My little 5'0" momos, if I can't sit, I'm dead by the time I'm done treating them, because I have had to crouch the entire time and my back is done, because sometimes their shoulders are at my waist. So I'm like down here, like crouching, trying to get at their level to where I can be where I'm supposed to be. So the stool is really great in that situation. Or the bedside commode, or the trash can turned over, because sometimes that's all I have to work with. There are no stools in the hospital. The trash cans turned over with a towel on top of them will work at a pinch. Especially the old metal ones. Sometimes you can adjust a bedside commode down pretty low. That will work sometimes in a pinch. Of course, they don't roll, but if you're just doing what we're going to be doing today with the standing, you don't need it to roll, because we're not moving. We're just standing. So once we get them in standing, we're going to do the same things in standing as we did in sitting. First, we have to establish static. Because if they can't stand, with or without assistance, if every time we stand them up from the high perch position, there's no progression from there. We can't even take them down to work on the sit to stands, because they need so much assistance to just be upright. They don't even have anti-gravity muscles, right? So we got to work on some strengthening first. So you got to build them up just like we did in sitting. You'll go back to that formula for standing. So we will do establish static standing balance. Then when we move to dynamic, we will move to dynamic in the box simple, in the box complex, out of the box simple, out of the box complex, just like we did before. And this is reaching with our arms again, or reaching with the good arm again. We're just not sitting doing it. Now we're standing and making them do very similar things as we did sitting. We might not be able to be quite as ambitious, because now they're standing on their own 2 feet and you are guarding them, versus them sitting here and you guarding them. So your activities may change a little, right? Same exact concept, but you may have to adjust your activities a bit, because you're going to have to be then watching the knee, making sure the hip stays engaged so that they don't have a loss of balance. And when is that loss of balance going to happen? When they go or when they come? When's it going to happen most often? They're going to have more trouble weight bearing on the limb that doesn't feel normal and that's weak. So stance is always going to be more difficult. Even though swing, they can't activate it. Stance is weighting and unweighting a leg that. So when they go, they're going on the good one. So you're thinking, oh, they're doing really well. So you may lighten up a little bit and say, okay. And then when they come back, the knee goes, whoomp.
It's really hard to get that knee to stay there too.
Yeah.
Like, it feels like a workout.
Yeah. So it's when they come back that they usually have more trouble. And then they don't normally have trouble necessarily reaching to this side because you've already got the knee locked and in position when you have them reach over this way. Make sense? It's when they take the weight off of this leg and then have to put it back on it that you're going to see the most issues and the most problems when we go to do the standing dynamic. And that will mostly be out of the box, but you have to be very careful even when you're doing in the box, because if you lose the knee, every time they weight bear over there, that knee has to be in extension. That is the key. And the hip has to stay, because if you throw the knee in extension and the hip does this, so you always have to know what kind of musculature you're dealing with in the hip and the knee when we're doing standing. Okay? Make sense? There's not a huge new concept to learn here. We're just adapting it to fit standing. Make sense? Somebody want to be my patient? Do you learn okay when I do things on you, or is it better when you watch?
I don't know. I don't know.
I'm recording it if you
Yeah.
watch it back.
Okay,
Nobody's gonna do it.
okay. I was just making sure. I mean, I love that you volunteer, but sometimes that makes it tough because then you didn't get to,
Yeah.
you know.
Yeah.
So, if we're going to take her and we're gonna say that her dynamic sitting balance is so that we are ready to take her into some sit to stand activities, and just for the purposes of making it easier with the remote, this is the weak side, so that I can hang on to the remote from here, and I mean I can drag it across her body, but and then these tables are a lot easier because you can just use your foot for all the rest of them. So but if I'm going to use the high-low table, your foot should always be in front of their foot. They should never be doing anything where you're raising the high-low table that you're not blocking the weak foot. Because they're not gonna really have tennis shoes on carpet. It's usually gonna be no slip socks on tile. And so as you go to raise this, so always get in the habit, muscle memory, just go ahead and learn it now. Put your foot in front of their, no, it's still not gonna slide on the carpet.
Yeah.
So, always put your foot in front of theirs. And then as we transition this position, it's real easy to get your leg in front of their leg from this position, so you don't really have to do a whole lot of readjustments from here. So, always just get in the habit and then you're gonna be close enough to kinda handle whatever. If you start from over here, cause they're sitting and, you know, they're good and safe right there, and we know their dynamic balance is at least good enough to be able to start the activity. And if you start out here and you start making her climb and something bad happens, you're not in a position to handle it. Even though technically right now she's safe, right? So just get in the habit as you're learning it, learn it in a safe way. So you're gonna go here. So the eventual goal, Carly, is that we're going to literally use the table to raise you up, where we've not really been standing too much. You know, your transfers are kind of standing, but not really. We've not really been spending any time there. So we're gonna start retraining your brain to be in an upright position, and we're gonna use the table to do most of the work, okay? So just, I want you to do what my hands and the table feel like you should do. Yeah. So, and a lot of times they'll just scoot that foot forward. Like it just, that's what I said, just do what feels natural. Do what feels like you should do to accommodate as the table goes up. So, a lot of times as you get higher and higher, they get a little hesitant because, you know, they're literally hanging off the edge. But, you know, you're so close and, you know, just really where they need you to be. Most of the time they're okay, but you may have to give them a little bit of encouragement, especially the first time you do the activity. But usually when you say the table's gonna do most of the work, then they're like, okay. Alright, we're gonna go ahead, let's put your hands down here. I want you to lean forward and rock over your toes. Now just do that 5 times for me. You keep count. Get them all in? Good. So I didn't count them for her, told her how many to do. If she would have kept doing them past 5, I would have asked her if she was using a different numerical system than me.
Counting paths?
Or tell her that she's doing more work because I'm not counting, you know, so. So you just want them to do this progression all the way up, right? The farther you get up, you don't want them to slide too far forward, so the farther you get up and the more weight that's coming forward through the feet, then you're gonna start blocking the knee. You don't want the hips to come off. Does it feel like you need to bring that one back? Okay. And so a lot of these movements they'll make themselves. They're gonna make the correction on that side, and they may try to make the correction on this side. That's about as high as I can get her. Okay? So, all of her weight is on the inside of my knee right here. So, not too bad uncomfortable. We've got it to where her boniness is against, like, my muscle. Okay? So then, okay, we're gonna bring your hands around. Now, both my hands are gonna go, like, right here. Pelvis. Bring it forward. Then I can lean her back against the table to just rest. Because all we're gonna do is see how her legs take her weight. That's what we're doing. How much do her legs take weight? That one's good. This one I've got locked. she's not going anywhere. If I have to, I can do this. Right? She's not going anywhere. I can do this, the hand, lower the bed. Set her down, and then throw her in supine if I need to. Right? Make sense? And then as you start to do the incremental sit to stands, about halfway up. So now that you're used to being up on your feet, we're gonna start the process of going sit to stand, okay? So nose over toes is real important. So I'm gonna have you get a hold of your weak hand. Yep. And then you're just gonna kind of reach out towards the room and up. Okay, push. Pop. Okay? You're gonna reach out and up. And I'm facilitating the glute while blocking the knee and the foot. You don't have to use the arms. You can leave them. Okay, so let's do it again. Leave them in your lap. So, nose over toes is important. So for this one, I would tell her nose over toes is important. So we're going to come forward over your toes and at the same time come up. Remember it said trunk flexion, or hip flexion and trunk extension were your keys, right? So you want her to come nose over toes, and then you want her to get extension of her trunk to activate, right? Okay, so back down. So I'm gonna block her foot and her knee on this side, depending on how strong this leg is or not. I may have to activate the hip, I may have to hold the hip in so that it doesn't drop out in extension, right? So, but if not, then it's okay. Do you remember what I said we were gonna do? Where does your nose go? Okay? And then you're gonna give what? A big push. So depending on the level, you may need to facilitate the glute just on this side. You may need to hold in the glute. You may need to pull up on the collarbone to get that trunk extension. So there are different varying levels of what they need for this depending on how strong they are. And if that is too difficult, then we raise the table a little bit until it's doable for her. Does that make sense? And then we keep it at that level until it's pretty easy, and then we lower it just a little bit to make it challenging again. So if that was too difficult for her with just those cues and facilitations, then we make the table higher to make it easier physically so that she can do the neuro part of it. Make sense? All right, let's practice that.